Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. We'll talk today, صوت واضح? About the intraoperative and postoperative complications of cataract surgery. By cataract surgery, we mean phacoemulsification mostly, and maybe ECCE, maybe ICCE, which are less commonly done nowadays. So to start with, we have intraoperative complications. First of all is block complication. We can have certain number of complications after block. I know most of the cases are done nowadays under topical anesthesia, but yet block sometimes is needed. And I do actually block my patients unless there is a contraindication for that. So first block complication is retrobulbar hemorrhage or peribulbar hemorrhage. Incidence is 1 to 3%, mostly occurring in patients who has bleeding diaphyses or are on anticoagulants. So what happens if retrobulbar or peribulbar hemorrhage occurs? There will be proptosis or bulging of the eye forward. Usually the eye bulges forward after you give the peribulbar anesthesia, but this is out of proportion. You will notice it to be bulging more than the fluid you are placing inside the eye. And there will be high intraocular pressure, and the lids become tense with ecchymosis. And if this was held long enough, this can compress on the optic nerve and cause optic atrophy. So you can see here in the picture how the conjunctiva is ballooned with 360 subconjunctival hemorrhage. So what we do in this situation, we try to massage the eye and trying to lower the intraocular pressure mechanically, and also IOP lowering agents. We can give mannitol, for example, to lower the intraocular pressure. And we can do lateral canthotomy. Lateral canthotomy usually alone is not enough. You have to find the inferior lateral ligament to severe, and this is called cantholysis. And also you can do an AC paracentesis, trying to lowering the pressure, or 360 conjunctival pyrotomy. What other block complications can happen? We have the globe perforation. The needle can go inside the globe, and this happens usually with longer eye, and if there is a presence of staphyloma, and you can verify this by looking at the B scan and making sure that there is no staphyloma and the eye is long. When the eye is long, we tend to be more careful. We can pass the needle parallel to the eye, or directing away from the eye toward the orbital floor, or if superiorly toward the orbital roof, or the wrong technique. Sometimes we just go in and we don't pay attention to where the equator is of the globe, and go inside the eye. So this happens usually with deep sunken eyes, where the eye is back there and you have to go around it. So you have to insert the needle away from the globe before turning. So even if you inserted a parallel needle to the globe in a deep sunken eye, you might hit the globe. So sometimes we discover this right away. The patient will feel very severe pain, but what if not? If we went ahead and do the operation, we will notice that the globe is soft, and the AC is deeper than usual, and there will be dim reflex due to vitreous hemorrhage, because the needle, when it goes inside, it causes some vitreous hemorrhage, and you can see this in the red reflex if the patient originally doesn't have a vitreous hemorrhage. And we have to refer to retina before or after, depending on when we discover this. If during the procedure, we tend to continue the procedure, and then we have to refer to retina to take over to do vitrectomy and tamponading of the retina. During the rixes, when we do the rixes, sometimes, or maybe this is most scary, that radial extension can happen when we are doing the rixes, especially at the start. And this is becoming more characteristic if there is intumescent cataract. If there is intumescent cataract, there is tendency of the rixes to go out. That's why we have to decompress the intumescent cataract before doing the rixes by either 27 gauge needle. We aspirate from the cortex, trying to decompress the pressure on the capsule that drives the rixes outward. So we can have a small rixes, smaller than needed. When we have smaller rixes, this is good for IOL centration, but it is bad during the phaco procedure, especially if you have large nucleus. You need really a large rixes to have, because if you have a small rixes, most of the tension you are exerting is transmitted to the zonules. So you don't want this, especially in hard nuclei. Large rixes, on the other hand, it is good for evacuating the lens and phacoemulsifying it, but it becomes less favorable when we place the IOL. You want actually the IOL to be covered from 360 degrees to prevent it from prolapsing forward and having subsequent pupillary capture, for example. So here in the bottom right, you can see the tumescent cataract, and that was decompressed before doing the rixes. In the upper right, you can see at 4 o'clock that there is a rixes extension that happened there. And this is the bottom left, the most favorable rixes size, in which that it is not small enough, but not very small, and large enough to cover the optics of the IOL. What if during the surgery we had a shallow chamber? This can be to many reasons, and among them is inadequate infusion of the BSS. So we have to make sure that the bottle height is good, it is not low. And it might be due to wound leak, especially if the wound is larger than the phaco probe, for example. If we made by accidental extended the wound, in this situation, we can either raise the bottle more, or having one suture at the periphery of the wound to make the wound tight enough to have a closed chamber to work on. Third reason can be a positive vitreous pressure. This happens usually in obese patients or short neck, or if he has a pulmonary disease, he's trying to do Valsalva, or an anxious patient. So you will encounter a shallow chamber during the surgery. Aqueous misdirection also can happen during the surgery, in which the aqueous can go to the vitreous cavity and pushing the iris lens diaphragm forward, causing shallowing of the chamber. Suprachoroidal hemorrhage, usually this is happen. Usually there will be dimming of the reflex, everything trying to come out, so you have to close. So what to do? Raise the bottle, suture the wound. If there is any, adjust the speculum. Sometimes the speculum is the thing. If we didn't cut the drape properly and we put the speculum, it will be pushing on the eye. So addressing these issues is as important as the FECU steps in order to achieve the best results. Intravenous mannitol we can use to decrease the pressure inside the eye and having a more roomy chamber. Aqueous misdirection, when it happens intraoperatively, the fluid gets misdirected to the vitreous cavity, as you can see here in the diagram, that the fluid comes behind the lens and pushes it forward. The anteriorly, the iris lens diaphragm becomes very shallow, and even if you try to form the eye by viscoelastic, you will notice that the viscoelastic will come back to you and the chamber is still shallow. So what to do? Simple measure. We can try to tap the lens and tapping the lens usually happens. Usually resolve the issue if the aqueous is there behind the lens, trapping the lens with the rhexis forward. And if we tap the lens, we are forcing the fluid from behind the lens to go to the front and evacuate it through the rhexis. IV mannitol can be tried, and sometimes we have to insert 19 gauge needle in the pars plana and aspirate if the chamber doesn't want to form. This is one method of doing it. I know that retina people will not like this because this can cause traction on the vitreous and so on and so forth, but this you might consider. And also pars plana vitrectomy is the ultimate resolution of aqueous misdirection. Posterior capsule rupture. Posterior capsule rupture, this is the most fearful complication of cataract surgery, and it can happen during any stage of the procedure. It can happen during nucleus removal. It can happen during cortical aspiration, or even as early as capsulorhexis with radial extension. If there is radial extension, it can go all the way to the posterior capsule. We can also do a vigorous hydrodissection. The pressure rises back to the lens and it can rupture. And I've seen cases in which with the hydrodissection alone, the nucleus disappeared. So it went back to the vitreous cavity due to vigorous hydrodissection. So keep this in mind. So what should we do? Most important of which is identifying when posterior capsule rupture happened. So if you don't have a hint that posterior capsule rupture happened, you'll continue your FECU and you'll cause this rupture to enlarge, and you can lose fragments into the posterior wall. So whenever you see the nucleus go back more than usual, or the nucleus is tilting, so stop and inject viscoelastic before you going out from the eye, and then go out the eye and then reassess the situation. Make sure that there is no capsule rupture, and whenever you're injecting visco behind the lens, it goes forward. These are some hints to which you can make sure that the capsule is intact before carrying on the procedure. Okay, so what if we couldn't salvage the posterior capsule and there is a vitreous already coming to the anterior chamber? And this also can happen even with the nucleus fragment are there in the anterior chamber. If vitreous prolapse happens, then anterior vitrectomy has to be done. So there is no way around it. I've seen people trying to compress it by visco, trying to get it back and then put the IOL in front of it. But it turned out that it goes through uh, beyond the IOL and goes forward. So whenever you identify there is vitreous, do a vitrectomy. Okay. Use a vitreous cutter, preferably with bimanual technique. Bimanual has the advantage of not inviting more vitreous. If you are using the coaxial, you are directing it, and the aspiration and irrigation pore are from the same probe, and you are inviting more vitreous to come. While if you have a bimanual and having the irrigation pore into the anterior chamber, you can cut only whatever vitreous is there in the anterior chamber, and you can compress the rest by the viscoelastic. Avoid wixel, vitreous traction. Sometimes we put a wixel and then pull it and cut. Put a wixel, pull it and cut. So this might seem plausible, but this has a disadvantage of having retinal traction. So this vitreous is connected to the vitreous base. And whenever you are pulling it, you are pulling on the vitreous base, and the vitreous base is connected to the retina, and this can cause break. Okay, and you don't want this to happen. Injecting steroid will facilitate the visualization of the strand. The vitreous is transparent, so you cannot see it, but you can have certain clues as to which there is a vitreous or not. One of them is seeing the borders of the posterior capsule rupture. If they are fixed, they mean that there is vitreous. They have to be moving and flappy for you to know that there is no vitreous. But how can we see it? We can see it by triamcinolone or steroid injection into the anterior chamber. You can see the vitreous strand, and you can go there and cut it. So what if we didn't cut the vitreous and leave it there? It can incarcerate into the wound, can cause inflammation. It can cause corneal decompensation. It can cause chronic or cystoid macular edema. What about dropped nucleus? Dropped nucleus is one of the fearful things, and this happens when usually you don't identify that there is a rupture, and you continue. And if you continued while there is a rupture, it will go large, and if it will go large, there will be lost fragment into the vitreous cavity. And this happens if rupture was created before complete removal of nucleus fragment. So anterior vitrectomy has to be done, cortical cleaning and IOL. So leave whatever sink there into the vitreous, leave it. Don't try, even if it seems close to you. Don't go ahead and chase it by the phaco probe. Leave it there, do anterior vitrectomy, put your IOL, and refer it to our retina colleague to take it out. Dropped IOL. This happens if the capsular support seems enough while it is not. So you have posterior capsule rupture, you did vitrectomy, cortical aspiration, and you think that it is enough to support the lens. So make sure that it is enough to support the lens, especially if you have a posterior capsule rupture and you want to place a lens in the bag. Make sure that you made it continuous posterior rhexis to make sure that it can accommodate the IOL without traction that can make the posterior capsule rupture more and you lose the IOL. So it is always better to leave the patient aphakic for future secondary IOL rather to complicate the surgery by a dropped IOL. Suppose you have a dropped nucleus and then you have a dropped IOL. So we'll hand it over to retina. They will not be happy. Zonal dialysis. Zonal dialysis happen when there is enough traction of the capsular bag to avulse the zonules, and it happens in patients with pseudoexfoliation, which are more prone to have this complication. If we have, especially with large nuclei or very hard nuclei, we tend to do vigorous maneuver, and we forget that there is a bag that is suspended by the zonules. So just keep this in mind. You don't want to disrupt the bag as much as possible. You are trying to do your phaco without disrupting the bag. Minimal displacement during cracking, minimal displacement. So I see people cracking like this, and then having the chopper and do certain maneuver that are not good for the zonules. If the zonules are good, this might withstand your procedure, but if the zonules are already bad, you don't want to do this. So if there is a zonal dialysis 180 degree or less, it can be tamponaded by capsular tension ring. Okay, but if it is more than 180 degrees, we have the choice of either suturing the bag by suturable Ahmed segment or Sayoni ring. We can just suture it and put it in place into the sclera, or we can disregard and take the whole bag and leave this patient for future secondary IOL, iris or scleral fixated IOL. Iris dialysis, it can happen with mechanical instrumentation. With the phaco probe, you can aspirate the iris, and you can detach it from the iris root by the phaco tip or the IOL. This is mostly with ECCE lenses that are PMMA, and with the insertion, sometimes we can severe the iris. The small ones can be left alone, especially if they are superior, they are covered by the lid, and can be regarded as peripheral iridotomy. But if it is big, it has to be sutured to the sclera to avoid the monocular diplopia that can arise. Wound burn can happen with the heat of the probe that can lead to the contraction of the corneal collagen with distortion of the wound. When this happens, you will notice the wound shrinking, and it is very difficult for suturing, especially with the hard nuclei. And sometimes we take a long time and leave the occlusion working while we are trying to shop the lens. Leaving the occlusion working for longer period of time increases the heat. So in the absence of the fluid through the wound, which is one of the methods that you can decrease the wound burn by, to irrigate the wound while doing phaco to the hard nuclei. So it will be difficult for corneal suturing, and you will notice that even a small wound that can need up to 4 or 5 sutures in order just to keep this wound integrity intact. And with that suturing, we can have a lot of surgically induced astigmatism that can happen due to that. Decimate detachment can cause localized corneal edema. Usually happens near the wound due to irrigation or separation of the instrument. You are going in and out through the incision, and you are applying some pressure to the decimate, and this will give rise to decimate detachment, especially even with the irrigation fluid can detach the decimate. The small detachment, usually around the wound, can be observed. They can self-attach by themselves, but the larger ones can be treated by air bubble in the AC with the proper positioning. So if the air tend always to go up, so if the detachment is superior, for example, you can have a patient in a semi-sitting position, to ensure that the air will go where the detachment is. If it is temporal, you can have the opposite side down so that it goes. What if we have it lower, any position of the patient for lower detachment, upside down? You can have hyperextending of the neck without a pillow so that the air can go to the inferior. So, and if the detachment is noticed to be large and it would take time, we can use expansile gauze like SF6, or even suturing has been reported to reattach the DSM. Suprachoroidal, this is the disaster of the cataract surgery, and there will be sudden increase in the intraocular pressure with dimming of the red reflex, and everything inside the eye wants to go outside of the eye. So if you are doing an ECC, for example, this will be a nightmare for you to try to suture. So the technique for that is put the finger inside the eye and try to suture as much as you can before everything comes out. Management consistent of immediate wound closure, digital pressure, posterior sclerotomy. Posterior sclerotomy, there is a debate about it, whether or not to do it on table or not. Some say that if you did it on table, this will be inciting more bleeding, and so on. On the other hand, if the pressure increased high enough, it will be tamponaded by itself. But this is has to be considered. It can happen also post-operatively. So these are the intraoperative complications. We'll move to the early post-operative complication. We have shallow chamber. First theater surgery, you open the eye, you find shallow chamber. You want to measure the intraocular pressure. So if the intraocular pressure is low, it can be a wound leak. It can be a choroidal effusion. So you have to test for that. If it is high pressure, it can be due to pupillary block, aqueous misdirection, or even suprachoroidal hemorrhage. So the wound leak can be asymptomatic, but the patient usually complaining of tearing. So pay attention to whatever the patient says in the first post-op day. If they say that there is tearing, so this you might need to check for leak. Intraocular pressure, you can have a low intraocular pressure, but still you can have a normal intraocular pressure or even high intraocular pressure with a wound leak. AC might be shallow or formed, diagnosed by sidal test. What to do? You have to use aqueous suppressant, topical timolol or Trusop, and we can decrease the topical steroid. If we are using the topical steroid more frequently, we can decrease it, or we can stop it for a day or so. In the past, there was a notion that you can use a gentamicin that is irritant and can cause the wound to close spontaneously. You can use a contact lens, pressure pass, but if all these measures didn't help, or there was a profuse bleeding, leaking to start with, you can go ahead and resuture the patient in the minor or the major OR. Wound gapping can be with or without leak. If iris becomes incarcerated there, it plugs there and it will no longer leak. IOP might be normal, AC formed, can give rise to blip formation if it happens under the conjunctiva. So observation, we can observe this unless there is irritation or shallow AC or significant hypotony that might cause maculopathy. We go ahead and suture this, or it is described cauterization of the wound gapping. Anterior segment bleeding, this can happen, usually originate from the root of the iris, usually resolve spontaneously, but antiplatelet, anticoagulant might need to be held if the medical agreed and the patient's general medical condition allows him to stop the anticoagulant. We can go ahead to stop it for a day or two, or as it might need. And washout is indicated if there is blood, corneal staining, or the IOP is not controlled medically. Choroidal effusion, the risk factors are hypertension, obesity, high myopia, anticoagulation, glaucoma, chronic ocular inflammation. All these can give rise to choroidal effusion, and it is listed with vacuum ossification rather than ECCE or ICCE, maybe a precursor of suprachoroidal hemorrhage. So it might start as choroidal effusion, but turn out later to be a suprachoroidal hemorrhage. The late suprachoroidal hemorrhage that can happen after you finish the surgery, the day 1, day 2, day 3, the patient will experience pain, decrease in vision, chamber will be shallow with high IOP. Treatment consists of IOP lowering agents while ensuring wound integrity. A surgical drainage is indicated if there is a persistent flat chamber or medically uncontrolled glaucoma, or if there were kissing choroids or persistent choroidal detachment that didn't resolve with time. This might be surgically drained by the retina. High intraocular pressure can happen day 1. High intraocular pressure can have viscoelastic material into the anterior chamber. We manage medically unless uncontrolled. We can go ahead and evacuate the viscoelastic. I remember one type of viscoelastic that were usually cause high intraocular pressure. It is not there nowadays, but we used to prescribe Diamox routinely for patients, and some patients had to go visco aspiration after the surgery. So this can cause high intraocular pressure. Another thing is pupillary block. It can result in shallow chamber and may follow a resolved wound leak. If the wound leak resolved, it can happen. Post-op uveitis, ACIOL, especially if you didn't do a PI with the ACIOL, pupillary block can happen. It needs a PI. Trial of dilation may break the attack. Aqueous misdirection, you have to keep it in mind, and suprachoroidal hemorrhage in cases with high intraocular pressure. So the aqueous misdirection can happen after surgery, but mostly this with trabeculectomy, but it has been reported after vacuum ossification and posterior chamber intraocular implantation. Posterior misdirection of aqueous to the vitreous cavity, it causes shallowing of the anterior chamber. Angle closure glaucoma patients are the most at risk. IOP is high despite the presence of the patent PI. So this might give you a clue that if there is a patent PI yet there is a shallow chamber, high IOP, this might be an aqueous misdirection. So for the medical management consists of IOP lowering agent and cycloplegic. So YAG capsulotomy, disruption of the anterior hyaloid face, we can have some of the aqueous goes there, and the chamber can form with the posterior capsulotomy, but the ultimate treatment for resistant aqueous misdirection is pars plana vitrectomy. High intraocular pressure happen with hyphemia, pupillary blockage, and endophthalmitis, retained lens material, iris pigment release, pre-existing glaucoma. So patients with pre-existing glaucoma can have sometimes high intraocular pressure because their angle are not usually working normally. So if there is a drop or some visco inside the eye, it is hardly to be drained from the eye, and they have high intraocular pressure. Steroid use and peripheral anterior synechia. So corneal edema can happen after surgery. Higher incidence with pre-existing endothelial dysfunction. It happens due to mechanical trauma, especially if you use high power. Prolonged irrigation. Sometimes we don't use high power, but we spend a lot of time during the surgery. With this spend time and the irrigation, we lose some cells even if we didn't use much power. Inflammation, high intraocular pressure, or toxic anterior chamber syndrome. The Brown-McLean syndrome, it's a peripheral corneal edema with a clearer center. It happens after ICC, so mostly you don't see it nowadays. Can progress to corneal decompensation. Endophthalmitis needs a lecture by itself, but it's characterized by pain, decreased vision, floaters, and photophobia, which happens usually second to fifth day after the surgery, and the patient presented with lid swelling, chemosis, decreased red reflex, hypopyon. So if you are in doubt the patient is having fibrinous reaction, for example, keep an eye on him and see him twice a day or something. Maybe he is cooking endophthalmitis. So urgent vitreous tap and intravitreal antibiotic has to be given on a spot. And if the vision is light perception, we can go ahead and do vitrectomy. Some articles, they advocated vitrectomy even if the vision didn't reach light perception, and they claim that it has a better outcome rather than vitreous tap intravitreal antibiotic. But if you don't have a retina surgeon, for example, this can buy you sometimes until vitrectomy is done. Cystoid macular edema, 1 to 2% incidence clinically, 1 to 11% angiographically, more with complicated surgery, posterior capsular rupture, and drop nucleus, Irving gas syndrome, it's called, may result from increased perifoveal capillary permeability due to generalized intraocular vascular instability. Other contributing factor is prostaglandin release, macular traction, transient or prolonged hypotony can result in cystoid macular edema. So it can resolve spontaneously. This is our CT picture of a patient with fluorescein angiogram that is demonstrating the macular edema. It can be treated by topical steroid, topical non-steroid, subtenon steroid, oral non-steroid, oral carbonic anhydrase inhibitor, and laser grid. And eventually, if none of these worked, vitrectomy has to be performed. Epithelial ingrowth. The epithelial ingrowth, it happens mostly after ECCE, and it's characterized by epithelium growing inward through an insecure wound to cover the corneal endothelium and the iris. So it goes both ways. Characterized by high intraocular pressure, abnormal iris surface, pupil distortion due to contraction of this epithelial ingrowth, visible retrocorneal membrane, and the classic way of identifying that if this is an epithelial ingrowth or not is to do an argon laser to the membrane. If it turns white, this means that it is an epithelium. Retained lens material, so after the surgery, you are happy and you come first day and you find some cortex into the anterior chamber. And this can give rise to uveitis, glaucoma, corneal edema, and vitreous opacity. Surgical removal is indicated in cases if there is persistent inflammation or there is medically uncontrolled glaucoma due to this, or if it is a large piece, if it is larger than third, they said that you have to take it out surgically. Less than this, you can just observe. Retinal tear or detachment, if this happens, you have to go in and evacuate this retained fragment or endophthalmitis, for example. Surgical removal shall be within 7 to 14 days. If you postpone it more than 14 days, this can give rise to chronic glaucoma or CME. Toxic anterior chamber, anterior segment syndrome, toxicity of corneal endothelium can happen due to certain irrigation solution. If the irrigation solution is not of the proper concentration, or if the intracameral injection are not of proper concentration, it might cause toxic anterior chamber syndrome. And it has been reported also with a conjunctival antibiotic, skin cleanser containing chlorhexidine. The corneal edema can be temporary or permanent. We have to differentiate it from endophthalmitis because from the severe reaction, they can even have hypopyon. So we have to differentiate it from endophthalmitis. The lids are normal, the conjunctiva are quiet, but sometimes this is tricky to differentiate. The treatment is by frequent steroid. If it resolved, well and good. If it didn't resolve, we have to do an endothelial transplantation for this patient. Uveitis glaucoma hyphema syndrome or UG syndrome usually happens with ACIOLs. Nowadays, we don't see this, maybe to appropriate sizing. Most of the time, we will not find an ACIOL that is readily available in the OR with the correct sizing, wide to wide, with the correct power. So we end up putting a lens that is not usually proper, and we end up with this uveitis glaucoma hyphema syndrome. Treated medically by topical steroids, anti-glaucoma. Surgical removal of IOL is indicated in resistant cases. Late postoperative complication, late IOL subluxation, pupillary capture can happen, as you can see here in the picture, superior and inferior. The lens is in front of the iris, and this is due to, especially if we put the lens in the sulcus, and there will be some adhesions between the iris and the anterior capsule. It can push the lens to be in front of the iris. Improper placement of the haptic, forward movement of the optic. Usually this results in a refractive error, usually myopia, usually asymptomatic, but it can occasionally give rise to glare, photophobia, monocular diplopia. Mydriatic can be tried in order to just make this IOL drop back to its original position, and then the pupil closes after this, but this is not usually working. So when we put a haptic into the sulcus and one haptic into the bag, usually this results in IOL subluxation, or there is insufficient zonular support. All the bag is displaced. This also can happen. A regular capsular bag contraction can happen, especially with patients with pseudoexfoliation. And it is managed according to the case by simple repositioning. You can just get the IOL back to its position. You can suture the IOL or to the iris or to the sclera, or suture the capsular bag, for example, or even removal of the decentered complex and put a later scleral fixated or ACIOL. Use as astigmatism. This happened with a tight suture. For the ECC wound, usually we relax the suture in 6 to 8 weeks. And wound gapping have against the rule astigmatism if there is a superior ECC. Refractive surprise can happen after the surgery, and this can be due to error in the perioperative IOL calculation. This used to be happening with when we used a scan. We put a probe into the cornea and we indent the cornea a little bit, giving rise to false axial length measurement, and we ended up with more powerful lens than needed and more myopia than needed. And IOL inversion during the insertion, so the IOL becomes upside down. As you know that there is angulation of the haptics to the optic. If this angulation is reversed, the effective position of the lens will change inside the eye, and this can give you rise to refractive surprise. Manufacturing defects can have to be kept in mind, mislabeling, or previous corneal refractive surgery, and this needs a lecture on itself, and how it gives refractive surprise. What to do? Glasses are the simple treatment. Contact lens. We can go ahead and change the lens, intraocular lens exchange, or we can put a piggyback lens. There are some lenses that are designed to be put over the original lens, especially if there is fibrosis already and you think that you will not be able to extract the intraocular lens without complication. You can go ahead and put a piggyback IOL or corneal refractive surgery for the refractive surprise. But for the corneal decompensation, usually happen with pre-existing endothelial, like Fox endothelial dystrophy or previous surgical trauma, a lot of surgery happening, and you are doing beautiful phaco and did it up with corneal decompensation. This is due to the fact that there is only few endothelial cell left, and you were the one that killed the remaining one and ended up with decompensation. Low endothelial count to start with also. Using much energy during phacoemulsification, hard cataract. Vitreous contact with the wound, if there is vitreous that is in contact with the wound, can go ahead and giving rise to decreased endothelium year by year and ending up with decompensation. Previous surgery are risk factors. So they will complain of pain due to the bully and decreased vision. There will be risk of corneal ulcer. Treat patient initially with a frequent steroid, bandage contact lens, and sodium chloride. If persisted with good visual potential, might need to transplant the endothelium in the form of LASIK or DMIC. But if there is no visual potential or the vision loss in this eye, you can go ahead and do a conjunctival flap. Chronic endophthalmitis can happen weeks or months after surgery, characterized by inflammation that subsides with the steroid. Whenever you stop the steroid, the inflammation comes back. And when you look at the picture, you'll find that there is some plaques on the capsule there. The treatment of which is intravitreal antibiotic or even the removal of the capsular bag complex that can be required to get rid of this problem. طيب طبعا low virulent organism like Propionibacterium acne is the most common of which that can cause chronic endophthalmitis. The posterior capsule opacity, the most common complication, it is reported to be around 28% in 5 years in one of the studies. It's due to epithelial cell proliferation of the lens. We have a certain nomenclature here. The somatic ring is the adhesion of the anterior and posterior capsule peripherally that can give rise to opacity peripherally. Oceaning piers, it is the outward migration of epithelial cells that can end up in a picture like this in the photo. The capsule fibrosis can arise from the transformation of the epithelial cells into myofibroblasts. The treatment is by YAG capsulotomy. Posterior capsule opacity risk factors are young age. They said that all patients young enough, they will develop eventually posterior capsule opacity. Intraocular inflammation, pseudoexfoliation, intraocular lens design, especially it doesn't have square edge, that is more prone to have epithelial cells migrated behind the lens. IOL material, acrylic, silicone PMMA, or silicone oil, these are all posterior capsule opacity risk factors. Anterior capsular phimosis, which is shrinking of the anterior capsule, and we see the capsular rhexis opening getting smaller and smaller with time. It has the same risk factor of the posterior capsular opacity. The symptoms include glare, especially at night when the pupil dilates beyond and there is some opacity in the periphery. The patient will complain of cloudy vision, and this occurs to start with. If we did a small rhexis, for example, it can contract and can give rise to this complication. Posterior capsule pseudoexfoliation, Marfan syndrome, surgical trauma. Plate haptic IOL are reported to have more capsular phimosis than others. Treatment is by YAG. We can do some radial extension of this phimotic capsule to give rise, clear the visual axis, for example. Corneal melting, sterile melting of the cornea. Keratolysis can happen in patients with pre-existing tear film instability due to collagen vascular disease. We have to do lubrication, punctal plug, lateral therapy can be necessary unless it is perforated. If it's perforated, we can have tissue glue, lamellar, or penetrating keratoplasty. Cyclodialysis, this used to happen when we use PMMA lenses. And this is the separation of the ciliary body from the scleral scale. It might result from manipulation of the IOL. We insert it vigorously inside the eye, causing this separation. And it can cause prolonged hypotony, in which case the cleft has to be sutured or closed by argon laser. Retinal detachment, incidence is less than 1%, occurs within 6 months of cataract surgery, or after capsulotomy. It can happen after even a simple procedure like capsulotomy. More with axial myopia, that is degeneration, previous tear or detachment of the same eye, if there is any. Retinal detachment of the fellow eye, posterior capsular tear, and vitreous loss are just risk factors for that. And post-YAG capsulotomy, it said in one study that it increased the risk by 4 folds if you did YAG laser capsulotomy. So we have to make sure that the patient is aware of the symptoms and can report to the ER if there is any, or you can do a retina checkup to make sure that there is no peripheral break or tear before you make your capsulotomy. So no visual improvement. We did the surgery, and after that, the patient didn't improve. In the absence of any organic cause, retinal toxicity can be a cause. Microscope light can burn RPE if proper filters are not used, can cause foveal burn or paracentral scotoma. Avoid or minimize exposure to coaxial light. The microscope has a diffuse light illumination and coaxial light. So whenever you are not using the coaxial light, so you can turn it off, especially if you are anticipating that you will take a longer period of time to avoid this phototoxicity. Thank you.